Blue Cross and Blue Shield of Texas is proud to partner with the Texas Tribune to provide free public events like the one you're about to see. These candid conversations are designed to promote public dialogue and civic engagement throughout the state.
I thought I might ask you to begin, and I'll let Chairman Zerwas go first. Give us your thumbnail overview of where we stand on the issue of health care in Texas today. We came out of the 2013 legislative session with much discussion of the topic, not an enormous amount of movement here in Texas toward a solution to the problems, the challenges we face. We're about to head into an election and then a legislative session. A new Congress will come in. Where do you see the landscape from this vantage point today in Texas, Chairman?
Just very quickly, one, thank you for having me here. It's always a pleasure to be on with Garnet Coleman. Garnet and I have worked closely on a whole number of issues. We don't always agree on the issues, clearly, but we have really agreed on, I think, on the big things that really make a difference out there. And so it's always a pleasure to be with him and to ride some of his coattails on some of the things that he's done. But I think right now we're in really a great period of transformation in healthcare in general. Not related just to what's going on in the state government, but also what's just happening in healthcare in general. And we're seeing this partly because of the Affordable Care Act, but partly because industry sees that we need to make a change, patients see that we need to make a change, and the insurance industry clearly sees that there needs to be probably a better way for us to drive high-quality, cost-effective care other than the way that we're doing it. And the way that we finance or pay for care is a big part of that. And I think that really gets to the crux of where I think that we are as far as this transformational effort. Clearly, the state government has a big role to play in that because of the Medicaid program. The Medicare program is all in the hands of Dr. Burgess, and so he can manage that. What happens in Medicare oftentimes reflects what happens in Medicaid, though clearly both being CMMS programs. But we are looking at a time where I would say, Evan, right now, we went into it with a pretty big issue last time.
Yep.
I think we go into it this session with a bigger issue. If for no other reason, the growth of the uninsured has in fact grown, hasn't shrunk.
Right. We think we're at about the last numbers I've seen, Chairman, 6.4 million plus or minus Texans without health insurance.
Correct. So we're seeing that grow, not shrink.
Yeah.
Not too surprising in light of the fact that we have a tremendous number of people coming to the state of Texas looking for great opportunities, and that's a good thing to have. But it comes with it, some needs that perhaps the state needs to look at in terms of how do we best leverage some of the opportunities that are out there for us in terms of meeting the needs of Texans that need their needs met.
You're actually reasonably cheerful, if I take measure of your affect here, about the prospects for something positive happening in the next 6 months, 12 months, or so on. You think there's reason to be optimistic?
I'm the eternal optimist, and most people will tell you that I live my life better being optimistic about what we can do going forward. Get me partway through the session next year, and you may see a different affect.
Right.
I may not be quite so optimistic.
Right. The session does tend to do that to people that elect office.
That's why you don't do these things right in the middle of the session.
No, always at the beginning. That's right. Representative Coleman, Chairman, I'm going to go out on a limb and say you're not as optimistic about the prospect of something good happening as Representative Zerwas is.
Well, the only reason I'm not as optimistic is because of the politics, because politics has driven health policy in Texas since 2003. So the challenge of getting something done means that the politics have to allow it to be done. And that doesn't mean that the majority of Republicans, both House and Senate members, 2 years ago weren't in favor of doing a Texas plan. They were. It's just that the politics wouldn't allow those bills to move to the floor.
Can you explain, for the benefit of the uninitiated, and we have very smart people in this audience who may not be as savvy about the politics of the Capitol. In my understanding of basic civics, if a majority of legislators in a body approve of something, it passes. What do you mean the majority approved, but the politics wouldn't permit it to go through?
Well, Governor Perry made it very clear that he would veto any bill that came across his desk. And because the politics of the day is in the Republican primary, there was no reason for members to go out and vote for something that they believed or thought would beat them in the Republican primary.
Yeah.
And quite frankly, I don't blame him. Because if the governor promised he would veto buy-in chip, and so we pulled it back because he was going to veto it. John had an excellent bill that I joint authored with him, and that bill would have done a really good job of moving us forward with some form of Texas plan on the ACA and bringing in dollars that would create some 375,000 jobs per year over 10 years and, and $90 billion. But the politics just didn't work. You know, Governor Perry went to the conservative PAC thing in Florida, and he made it clear that anybody who supported a Medicaid expansion of any type, that they were not a good party person. And he had a great press conference with John Cornyn and with Ted Cruz and with all the other statewide elected officials. So he made it very clear that this was not good politics for him. Now, running for president, the question is, assuming that's what he's going to do, does he put, if let's just say Abbott wins the governor's race, does he say, Abbott, you can't do anything because you're going to mess up my presidential run if Texas moves forward in the next session doing some kind of Texas plan on expansion? So it's the politics of that, not the actual benefit of the policy, because most people believe that the policy will benefit members, will benefit their communities financially, will create jobs that have good retirement, healthy coverage itself, is a good part of advancing our economy. And so we're in just a conundrum.
Right. Chairman Zerwas, is that your view that there was more support on the policy end, but not the support on the politics end, and that's why?
Oh, clearly, yeah. If we look at the House bill that Chairman Coleman and I carried during the last session.
And please explain what it would have done.
Yeah, basically this was 1371, 91. I'm never good on numbers. Somebody else does it better than me. But it was a bill that that got kind of nicknamed the Texas Solution, and the bill really would not have mandated or anything the governor or the commissioner to go up there and negotiate something for Medicaid expansion. It certainly was not an automatic expansion of the Medicaid system to take up these 1 to 1.5 million people that fall in the 138% below federal poverty level into the Medicaid program. It was basically a set of principles that we wanted the governor and the commissioner to have with them as they went and negotiated an alternative to Medicaid, and we called that the Texas Solution. And so we had a lot of support around it.
Yep.
I got it through the Appropriations Committee with the help of a lot of people, including Chairman Coleman. And then it got stuck in calendars, which, as we know in the House, that's a place where bills can get stuck for any number of reasons, and mine was one of them. It unfortunately got characterized as Medicaid expansion. I got characterized as, loving the support of the Affordable Care Act and wanting to try to, help implement its purpose and so forth, and that's fine. I can deal with all that kind of stuff. The point was, as I looked at it, I said, look, one, this doesn't do that. And I said, in fact, the whole first page of the bill is dedicated to why we feel like we should get a block grant for the entire Medicaid program. And that's really where we think that the real value in doing any of this. That being said, and the likelihood that we're not going to get a block grant for Medicaid, especially since we had asked for one under the friendly Bush administration and didn't get it, yet Rhode Island did. Good grief, how embarrassing is that? And so we didn't get it. So, here's just reality. That's what I would like to see. I know Chairman Coleman doesn't agree with me on that, but he was willing to sign on to this bill despite that. And said, if we can't get the block grant, let's do something with this 1 to 1.5 million people that we don't have a solution for. The federal exchange does not offer a solution for these people. The solution that we have right now is the safety net. And I stand here today saying, I don't think that's a solution for health care access. I think it's a way to prevent you from falling through the cracks when you have a disease entity that needs to be treated in some urgent or emergent fashion, but it doesn't provide you that access when you have early stage breast cancer versus later stage breast cancer. It doesn't provide you that avenue to access health care when you've got diabetes and early in your disease you're trying to get control of your diabetes so you don't end up with the serious sequelae such as blindness and heart failure and all the neuropathies and diseases that come along with that, in fact. And so, you know, this is, I know it's a long-winded answer here, Evan, for why we were going down this road. It said basically, go up there, negotiate a deal, incorporate these principles that, in my mind, what we said, these are the kinds of things that we think promote responsible healthcare behaviors. And that's the thing that we're trying to differentiate from the current Medicaid program where, again, this is me talking, not the chairman, that perhaps that sort of fosters what I call entitlement mentalities, which is, I don't have to worry about my health care. There's somebody out there to pick it up for me. Right. And so that at the end of the day was where the bill went. And and then the third part of it, Evan, was that there was a legislative oversight committee. It says, okay, we're going to put a legislative committee together that's going to oversee this activity for what it's
essentially worth. A chaperone. Right.
Basically, exactly.
Yeah. So the politics of last session, you seem to be in agreement, made it impossible to get something along the lines of what you had proposed done. Do you view, Chairman Zerwas, the possibility of such a bill being easier to get done in the next session or harder? Do you intend to bring it back up?
I'm going to be the optimist here. I don't know if I'm the right person to bring it up, frankly, because as we know, when you get framed in a certain way around an issue, sometimes it's better to have new blood and others look at it differently and stuff.
But you'd like to see it come back up?
I would like for us to have the conversation around it again. And that's what it didn't have. It didn't have the formal conversation on the floor of the House that I thought it deserved because it was, as you pointed out, a headline issue during the 83rd session. And it was the only bill that was going to give us the opportunity to have that debate and conversation. And again, I feel like once you laid out, and the chairman's already done this to some extent, once you lay out the benefits of what is allowed in the Affordable Care Act, not to mention that people get some kind of insurance, but when you look at the economic benefits of it, which are the jobs, which is the tax relief in these hospital authority counties and so forth, which is the stimulation to the economy. I think people would start to look at this and say, I've heard a lot from my chambers of commerce on this. I've heard a lot from my county judge on this. I've heard a lot from business, doctors, hospitals. And you say, well, who's not for this? Who's not for this from whatever point of view you come from? I think that it would stand the opportunity to convince people that this is a place that we ought to go. Now, one of the things I've also said on this deal, okay, if you're a person who doesn't believe the federal government's going to live up to its 90% promise in perpetuity.
Something that we hear quite a bit about the Affordable Care Act.
Frankly, I have some of that concern that the federal, nothing, Congressman, and it pointed at you at all by any means. But I have that concern that they're not going to. They're going to eventually migrate back to the 60% share that they give.
Stick you all with the bill.
Because there's obviously a budget issue at the federal level. And so I would say, do we have the will to walk away from this if that's the case? Do we have the will to walk away if the federal government does not live up to its 90%?
And so you'd want to see a trap door built into anything that passed in order to make
I'd say fine. Let's talk about that because what's the worst that can happen? It's what we're in right now.
Chairman Coleman, you know the politics of the legislature that is likely to be seated and gavelled in January. A few clicks more conservative on the House side, quite a bit more conservative on the Senate side. Is that legislature any likelier to receive such a bill, either authored by Representative Zerwas or anybody else favorably, more so than the last legislature was?
Well, the last legislature, particularly in the House, was very conservative, but even the conservatives understood that their communities would benefit from the boost financially, from the jobs that were created, how those dollars turned in the economy, what would allow people who didn't have access to health care, particularly a 55-year-old divorced woman that didn't have that access, that they wanted that, and they saw it as valuable. Now, will they still see the merits of those dollars as valuable? Yeah. Will the politics allow those merits to move forward? That's the toughest part.
Right.
And I think that it's, I hate to say it's less likely, but I'm like Chairman Zerwas, hope springs eternal. Something happens in our society, and with the bullying bill, I carried it for 5 sessions. 3 people died and Diane Patrick passed it.
Yeah.
It's because things happen that tell people that the time is now.
So a precipitating event or series of events may occur.
I think a precipitating event could do that. I think if everybody with cancer who didn't have health insurance stood up and said, the reason I can get care now is because of the Affordable Care Act and I can buy insurance,
right.
Then people would say, wait a minute, I get that.
Right.
Or somebody, as Chairman Zerwas said, with diabetes, who can stay out of the hospital because they now have access.
Right.
I mean, these are the things that are clearly working under the Affordable Care Act. But I agree with Chairman Zerwas. No, the 90% moving forward doesn't stay in. We should be able to get out.
Right.
Because it wasn't designed for the state to pay the bulk of the money. And I think that it was good the way that things were written because it allows us to continue CHIP going well and things like that. But the politics, I mean, you know, the politics are thick. And
they always are.
Right. But the problem with it is, instead of saying we hate Democrats, what has been said is we hate any Republican who even acts like they think that this is a good idea. And that is what's creating, I think, a big challenge.
Right. Let me raise you brought the Affordable Care Act up and the degree to which in the year or so that we've seen this in place, it has or has not been successful. So it was Chairman Burgess and Representative Howard and Commissioner Janik and I sat up on the stage a year ago. It was not yet October 1st. We had not yet hit the point when the website would blow up and that would overwhelm every other bit of news about the Affordable Care Act. But, you know, we made a decision as a state not to create a state exchange, to throw ourselves into the federal exchange. So these numbers are, in some respects, based on that mechanism. But it is said that more than 700,000 people in Texas have at this point signed up for insurance.
733,000.
You know, I knew you would know the exact number. 733. I rounded down. 733,000.
PolitiFact.
Do we take that, Chairman Zerwas, as a sign of some progress despite our antipathy to the Affordable Care Act, that it is having an impact on people in Texas?
Well, I think it's, again, you do have to look at the numbers. I will tell you, one of those 733,000 is my son. But my son was insured. And he lost his insurance as a consequence of the Affordable Care Act because the policy was discontinued. He got on the website. At that point, he's right next to that final deadline. And at that time, the website had been worked out. And it did. It worked fine. You know, there weren't any problems with it. Found the program. I said, okay, Joseph, get this basically, in essence, the same policy that you had before, you know.
Right.
And he did. But it wasn't as robust. But it did cost 50% more.
So it's more expensive, the policy itself was less robust.
So there are within those numbers the people who did get knocked down as a consequence of the health.
Well, in fact, it said that about 3 in 4 people who are part of that 733,000 were actually people who had insurance previously. So it doesn't directly affect the 6.4 the way that the number 733 would seem to.
So I think the biggest thing that you can take from that is, and the number's far from, you know, resolving our uninsured problem is that it does work. You know, the exchange does work, and there are policies out there. And I think when the incentives and disincentives start to align, and they aren't right now. In other words, it's more cost effective for somebody to not pay the insurance, you know, versus the penalty. When that flips, then I think that there probably will be more uptake. Obviously, the economics will drive it and stuff.
Right. So, but what you've seen over the last year has not changed your mind about the wisdom of a full-throated embrace of this legislation.
You know, I think that, well, you know, in general, I'm not a cheerleader for it by any means.
Right.
What I am a cheerleader for is the ability of everybody to have access to the extent that we can to health care insurance that will promote responsible healthcare behaviors.
Right.
And so that I am a cheerleader for. And there are a lot of ways to get there. I may not be the biggest cheerleader and proponent for this particular way of getting there, but I accept the law being what it is, and I accept the fact that there are billions of dollars that can come to the state of Texas right now under this law that would allow us, first and foremost, to probably through some kind of waiver insure these people that we don't have a solution for, and that would create huge number of healthcare jobs. Healthcare people like to spend their money, so they're going to support the economy. and there is the potential to see tax relief in areas that currently are burdened by a health authority out there. And the other part of it, we looked at it when we were looking at this particular bill was, okay, where's the money going to come from for the 10% ultimately that we would have to bear?
Right.
I said, well, let's look at what the premium tax is that comes off these new policies that are getting out there. I said, if the federal exchange really starts to spins off a lot of these policies, there's going to be premium tax paid.
Yep.
And that is a source of revenue that, at least on our back of the napkin numbers, doing it based on various levels of pickup, that we could probably, look at that as a new source of revenue that would probably cover that 10%.
Cover the 10%.
So we're not looking at a source of revenue from the current revenue that we have today.
Right, Chairman, you were more of a fan of the Affordable Care Act as proposed, and have been more of a fan of it, I'm going to say again, I'm taking a guess here, than Chairman Zerwas has been. Do you acknowledge some of the issues that he's raised?
Oh, I think those issues exist. There are a lot of issues that exist. Nothing has ever been perfect, but the need to cover the uninsured is a policy goal that I've been trying to solve in Texas since I got in the legislature in 1991.
Yep.
And I think that in this state, we are really the poster child for people who don't have access to health care with a payment. And because of that, we need to do something. Now, the market was already shifting to some of these solutions. Let's just take Blue Cross Blue Shield. They are bullish on this, or else they wouldn't have gotten in the market in the exchange. Since the enrollment has been done, other insurance companies have said we're going to also join the exchange and be a part of this marketplace. So they've said we're going to try this and make sure that we're involved in this, and this is going to be part of our business plan. So I think that in the long run, that people with pre-existing conditions, or like one of my constituents who couldn't get care because she had cancer, who was able to sign up under the Affordable Care Act and actually get a subsidy in order to get her cancer treatment. It really worked for her.
Yep.
So I think the intent was to make sure that people had access to a good insurance policy at a reasonable price. And everything says now that health inflation, or the cost of health care, has gone up less than it ever has in the recent future.
Which you attribute directly back to this.
But it is, because in even looking at Medicare in the deficit moving forward, we actually have a better outlook for Medicare, and we have a better outlook for the deficit based on the enrollment. Yep. But I'll tell anybody this, we have to do 1 to 2 years of this before we know actually how it's worked, because we're not able to get the data to search to see what needs to change. And any policy that we do, any policy that government does, has to be tweaked. It has to be. Nothing is perfect when it's rolled out. And that's why unintended consequences, we must go back and make sure that we correct the unintended consequences. Yep. So I'm dependent upon the congressman and whoever's there when they go through, if Republicans take the Senate and the presidency in 2016, to fix it the way that they fix it, but don't throw it out.
Well, let's actually go to that point specifically on the subject of politics before we get back to the magnitude of the problem. The likelihood, I would say the almost certainty going into this November, is that the Republicans are going to retain the U.S. House, add a few seats. And, there's a better than 50% chance, veering to 60%, that the Republicans are going to take the Senate. In neither case will the Republicans have a veto-proof majority. That's right. The president will be in office for the next 2 years. So should we just all go on holiday until 2016? Because it appears that what we're headed for are the last 2 years of the second term of a president who is going to have a hard time getting anything done. Congress is going to be able to prevent the president from getting anything done, but at the same time, there's not really going to be an opportunity to get too much done, given the fact that the president will still enjoy the power of the veto pen. So how do the federal politics likely, Chairman Zerwas, to come over the next 2 years impact the conversations that take place back here?
Well, I think we've already had a taste of it, and that's similar to what we've seen before.
Right. This wasn't exactly the last 2 years a period of getting a whole lot done, so maybe we're not going to be that different from where we were.
So, there are some intense political and ideological differences
Yeah.
within both chambers. And the numbers, as you have pointed out, are not likely to change enough that you could override a president who has some very strong political principles and ideology.
Yeah.
And so I don't see anything changing, this being year 7 and 8 for the president, unlike when Bill Clinton had those bad first couple of years, pivoted and moved into a position of more negotiating with Congress and so forth.
Right.
So I don't see that happening. If it did, I would be pleasantly surprised.
Right.
But I don't hold out any ambition that all happen.
So in the next legislative session, to come back to Texas for a second, we have already a new chair of Health and Human Services in the Texas Senate, Charles Schwartner, who is a medical doctor, replaced Jane Nelson, known to many people around here as a senator representing Flower Mound and parts of North Texas. And she's now chairing the Finance Committee, so Dr. Schwartner is now chairing the Health and Human Services Committee. I alluded to the fact that we're going to have a vacancy. Whether or not Representative Colkhorst wins that Senate race, she's likely not to be chair again of Public Health, so we'll have a new chair, you or somebody else, Representative Zerwas, of that committee. What does having 2 new people in those jobs mean for the discussion that will take place? New chair on the House side, new chair on the Senate side, in trying to get some of these things done.
Well, I think that whoever it is will be somebody pretty well seasoned, though maybe not as the chair.
Yeah.
Will be pretty well seasoned in that role. And Chairman Schwartner, I think, he's obviously, his life is in healthcare.
Yep.
He has come up to speed, I think, pretty quickly on the legislative perspective.
Right, relatively new to the legislature over in years,
relatively
has
new,
risen up pretty quickly.
Yeah, risen up pretty quick, and really it gets his arms around the whole health policy pretty fast, and so I think we're pretty strong there. I think really to a larger extent, it's the new chair of finance on the Senate side and the yet to be determined.
We'll have a new chair of appropriations on the House side.
Correct, and
right.
So I think that's a
we're going to have a new lieutenant governor, whichever way it goes.
New lieutenant governor, and so whoever ends up shepherding the Article 2 of the budget, whether it be me again or somebody else, I think we'll probably still have a pretty good understanding of it and so forth, and so I don't remain too that as if things will be that much different, frankly.
Right.
Yeah.
Chairman Schwartner, Chairman Coleman had a hearing last week, actually, his maiden voyage as chair of that committee, in which there was testimony about the predicament that we find ourselves in with regard to cost and uncompensated care costs being borne by the various counties. He seemed to be open to some kind of a discussion of what we might do. Clearly, he's not changed his position on the Affordable Care Act or expansion of Medicaid, but he seemed to be open to entertaining ideas of what we might be able to do to move the ball forward.
Well, the county judges have come forward and said that, they need assistance in order to continue serving indigent Texans.
Yeah.
And particularly in the major counties. Now, my county, our county judge, Judge Emmett, that, is a Republican, and he understands how important it is to have indigent care, but indigent care can't do it alone.
Yeah.
And so by bringing these local tax dollars together with state tax dollars and federal tax dollars, we can make some change.
Right.
And that's why they went to the committee. That's where the County Affairs Committee comes in. We have jurisdiction over all county expenditures, and it's county expenditures that are paying for the Medicaid program in Texas.
The county judges estimated in their letter to the committee that the uncompensated care costs were north of $4 billion.
That's correct.
When Commissioner Janik made his presentation to the committee, he actually estimated that in 2012 the uncompensated care costs were north of $6 billion.
Well, and they may be, but it's how you use your money.
Yeah.
And that's one of the things that we need to get a better handle on. The state of Texas should have never leaned on the counties 100% to pay for things.
Yep.
That was a mistake. And now when we come forward and we look at how we bring more money down through the 1115 waiver, that's totally dependent upon intergovernmental transfer from the counties.
Yep.
And some money that wasn't matched by the state in mental health. So we have to look at this as a whole system, both federal, state, and local, in order to serve the people of the state of Texas. So this is where we are. So I think it doesn't work. But the picture has been skewed a little bit. Ever since Rob Janelle was chair of appropriations, we haven't fully funded Medicaid in Texas, and we always have to do a supplemental or emergency appropriations because the total numbers have not been appropriated. So the actual crisis is not as big a crisis as it looks because we're 500 million short because we didn't put the 500 million in the program.
Yeah.
So we have to look at these things and see how to best run our programs or run our system in terms of cost, but also how to best use our local funds and how to best use our federal funds.
You acknowledge, Chairman, the crisis. People use the word crisis attached to a lot of different things, and in some ways the word has ceased to have meaning because everything is a crisis these days. On the other hand, we know it has been said that for years and years the largest percentage of the unrestricted portion of the Texas budget was public education, but that these days the cost of healthcare has grown so quickly that it has risen to meet and possibly exceed. That would sound to me like a crisis.
Well, being a former appropriator for 10 years, I can tell you that the reality is people play with those numbers. So if you want to make the number in Medicaid sound high, you use an all funds number. And then that's compared to the actual state funds number of public education. If you want to make the number seem low, you use a state number and compare it to...
So do apples to apples.
So apples to apples, it has gone up. But since I've been in the legislature, I went in, we had 18 million people, we have 25 million people.
Right, or more.
Or more. Yeah. And the percentage of people that we have that are low income is actually going up, not down. So it's not a surprise that the number of enrollees in Medicaid, because it is an entitlement program, has gone up based on the population.
Do you, Chairman Zerwas, take issue with the characterization by some, maybe some in this room, that this is a crisis? The percentage of, and raw numbers of our population without insurance, the costs that are incurred by the counties, whether it's $4 billion or $6 billion, the overall percentage of the budget that is represented by healthcare costs. Do you perceive this to be a crisis?
Well, I'd probably better characterize it in my medical background as a chronic disease that's on the verge of falling into a crisis. You know, in other words, we're sort of struggling along with it. We're sort of making things work, you know, but as we go along the way here, it could trip up and we could have some major problems.
Are we at a point where we have to take the kind of action that one takes in crisis conditions or near them?
Well, I think if we want to avoid crisis, we need to step forward and do it because, as has been pointed out, the numbers are going up; they're not going down.
Right.
The number of people enrolled in our Medicaid program, of which is about probably 81% uptake right now, is continuing to increase, and we anticipate that it will continue to increase and get up into the 90% level uptake. There's obviously cost associated with that. And you know, we're going to have to step up. We're not in a crisis, I would say, from a state perspective on funding like we were last time. We didn't leave a $4 billion hole this time that we left last time, but we're going to have about $1 billion hole when we come back in.
But of course, we're going to have more money thanks to the oil and gas industry and the general health of the economy. We're likely to have more money available to us in this next session.
So much so that we're having a ballot initiative to spend $1.4 billion of that a year in perpetuity.
This would be on transportation.
On transportation. Well, that's an expenditure.
Yeah. Well, let me come to this question of the growth because I think you both have alluded to the fact that the numbers are getting larger. We know that the population of the state has grown dramatically. In fact, we brag about how quickly the population has grown. The governor and others say we're adding 1,000 people to the state's population rolls a day, and the census numbers have backed that up. We're now at 26.5, approaching 27 million Texans. All these people who are coming to the state of Texas are not bringing health care with them. Right? They're expecting to find health care here. One way to look at this is that we're actually on the verge of being victims of our own success. We've become so robust economically and attracted so many people that now we're beginning to strain, right, at the growth that we're experiencing. How did demographics and how does population change, both in volume and also in the composition of the population, Representative Zerwas, play into this?
Well, I think it plays in hugely because every bit of that is exactly what the state programs are all impacted by.
Right.
And so whether it be education, infrastructure,
any of the social infrastructure issues, or physical, right?
Yeah, I mean, it's impacted by all of that. Uniquely in the healthcare arena, it's our more indigent populations, you know, and to what extent are individuals coming that can find access to health care. We're talking about health care insurance. There's plenty of great opportunities for people to get health care if you have the right means in order to get through the door. And by means, what I mean is some type of insurance program, whether it be Medicaid, Medicare, CHIP, private insurance, health savings account, whatever. That's your ability to get into the healthcare unobstructed, and so that you can access MD Anderson if you want to access MD Anderson for healthcare services related to cancer and so forth. So there's plenty of facilities and opportunities for that. The question is are the people coming and getting the kinds of jobs that are going to allow them to access healthcare in some form or fashion? The exchange is seen as part of the remedy to that, and I think we've yet to see it fully flourish. You know, not because it's necessarily a federal exchange, but because we just have yet to see, as the chairman said, it takes time for these things to ramp up and really see what the benefit of them is and so forth.
Chairman Coleman, it's not just the growth of the population, but also, as you know, we're moving toward Hispanic majority population in the state of Texas. So does the change in the composition of the population present a particular challenge as we talk about these issues, in addition to just the simple growth of the population?
Yes, it does, because if you look at the income levels of the individuals who are becoming the majority, which is directly tied to the education level of those individuals who are becoming the majority, that says what we're going to be in the future. And if those folks can't get jobs that have insurance, or if they're working 3 part-time jobs and have no insurance, because they would be eligible for Medicaid, and we don't do Medicaid for adults, or if they weren't citizens, we got a problem. And I think that problem even extends not to just Latinos, but it extends to low-income Anglos that we don't see every day because they live in a trailer out in Montgomery County. We don't see them. And they need exactly the same things. They need good schools, they need good jobs. And the same applies to African Americans and Asians. We have to look at our overall population for success, and healthcare is a part of that. Education and healthcare. And I think that our focus has been wrong in terms of having a good future. And a good future comes from having people who can succeed. And it requires good healthcare, good education to succeed. And I think that's one of the challenges that we have. If a person can't get a good job, they're not going to have good healthcare, and they're not going to, their children and they are not going to have a good future. So this all kind of goes together.
It's all of a piece.
Right.
We're going to go to questions in the audience in a second, and we'll have microphones walked around to your table. So we'll ask that you raise your hand, and when you see somebody come, snatch that microphone, and we'll have you ask your questions so that it can be captured on camera, and we'll give these guys an opportunity as long as they can to answer it. Let me ask you one question while we're getting our mic set, each of you. Fast forward to the end of next legislative session. I'm tempted to say the end of May, but we know the last couple times it hasn't been the end of May. It's why we don't plan for vacations in odd-numbered years during the summer. We know better than to do that. But let's get to whenever the end of the legislative session is next time. What do you think the likeliest outcome is on health care? What will be the big policy takeaway, given what you know, come next, end of May, beginning of June? Chairman.
Well, just from a fiscal point of view, I will say it'll probably be similar to what we've had before, and as the chairman has pointed out, we'll have adequate monies to comfortably fund the Medicaid program in its current enrollment and the expectations of increase in enrollment. And I think that from numbers we're hearing and things we're talking about, I think we'll have a little better sense of what the increased enrollment will be, and therefore appropriate funding of that. Because we are enjoying a very robust economy and we continue to enjoy that, I think we'll have plenty of money even in the circumstance that we perhaps shortchange it somewhat going into the end of it. And
but no big policy change that you can foresee coming down the road.
I'm an optimist, but I may not be that much of an optimist.
Even the optimist is not entirely optimistic.
Even that. I will say though that there are activities going on out there right now that are demonstrating some pretty good projects demonstrating savings of cost, improvement of quality, and coordinated care. And I think that if we could somehow really catalyze those and see them replicated across larger swaths of the population and so forth, we'll see cost of care come in, we'll see quality of care ultimately improve. And I think that ultimately we'll see this reining in of the cost of care. We're seeing some of that now. Blue Cross Blue Shield has been associated with it. Others have been associated with it out there. And I think that we're proving the concept pretty well. Really the difficult situation we're in right now is we all know and feel that this is probably a better way to deliver health care.
Yep.
And the people that do it right will do very well in terms of delivering care and will do very well financially. But tomorrow I've got to pay my bills, and I pay my bills by getting paid for what I do. You know?
Right.
And that's kind of the conundrum that we find ourselves in, and that if we can find a way that we can really sort of catalyze this way that we reward cost effectiveness and quality, I think that we will see a major shift in the way healthcare is delivered.
How much more optimistic are you about big policy changes?
Well, I'm optimistic that maybe we can take some things that don't get as much attention, like the 1115 waiver, and use it to make big policy change from. Maybe not a Medicaid expansion or a Texas solution, but look at how we can make changes along with the private sector that's already reaching out to do things that are different than what we're doing now. I think one of the big deals in Medicaid that we can do, and it may not be considered a major policy change, but that's to pay the providers the rates so that they can participate in the program. So then that way, the people get the best care and the program actually works. And I think that by saying a program doesn't work, that's not enough. You have to look at why it doesn't work. And people are starting to drop, hospitals and doctors drop Medicaid. One last piece I think is really important. We had a physician call our office, an orthopedic surgeon. And in Houston, he said that basically the only hospital that would do certain orthopedic work because of a $150 screw that isn't paid for by our Medicaid program is now the hospital district, is now Ben Taub. Herman, St. Luke's, Methodist, and Memorial will not do that surgery. So these are the types of things that we have to look at to see whether it's worth somebody participating in a program so that it works. That's a big policy change, by the way. And any HMO or, health plan in here or any doctor would tell you, in hospital, that's a big policy change if you use the dollars you have.
So you think there's a possibility that you could accomplish some of that?
I think so, because it's not, the reason I think it is because it's not a change that really requires anything but the people on the Appropriations Committee to make the change.
Okay, let's go to questions from the audience. We'll have a number of good hands up already. Microphones will be walked around to those guys. You got one? Good for you. All right, yes, sir.
Yes, hi. I'm relatively new to Texas. I've lived here for 4 years.
Welcome.
Thanks. And the question is generally addressed. You're talking about intergovernmental transfers, and the counties pay the indigent care. So is that a political issue with the counties versus the state government, or does that reflect itself in intergovernmental transfers from the state to the county, and then the county then lowers their taxes on the hospital districts?
Well, we haven't gotten there yet, but right now we're using the intergovernmental transfer to do an 1115 transformation waiver. The fight actually is not the state and the local government, it's the public hospitals versus the private hospitals, and the 50% portion of those dollars that come back through the old UPL program being part of the uncompensated care pool versus the DISH pool. And in last session, Chairman Zerwas really did a good job on this. The state, for the first time, appropriated money to help pay for the DISH pool that would provide dollars both to the private hospitals, which meant that the public hospitals didn't have to do more IGT with their tax dollars. So we made a lot of progress in that regard. So I think that the idea that the amount of UPL, upper payment limit dollars in our 1115 waiver you see, they go down. And that is part of a real problem. That means loss of dollars to private hospitals that came in to take care of the uncompensated care that they eat, and that's a real challenge. And Chairman Zerwas on appropriations has done an excellent job. Now, I have to do my little commercial for Chairman Zerwas. I believe that he probably has just as good a chance of being chairman of appropriations as he does being chairman of public health.
Well, you've just probably killed it then.
No. No, the reason I think so is because just what you just said, we need a new chair of appropriations. If you have something that's a big part of the budget, you want someone who understands the balance between those things. And I think that's extremely important. And his time on the conference committee of the budget is, how many times have you been now? 3, 4? 3.
He's a veteran, that's right. Okay, thank you for being helpful and directing my attention back.
Theoretically, if there were a lot of Republicans in favor of some form of a Texas solution, and all the Democrats voted for it, there would have been enough votes to override the governor. But it seems to be that the bottom line is the primaries. Is that correct? So what kind of cover, what do we do to help people in the primaries so we can get a legislature that really does relate to the needs of the state and the majority of the constituents?
Well, I'll take a stab at that, just because I'm kind of
since the primary is over, Representative Zerwas would be happy to take it. Right? Yeah.
Well, you know, I think clearly if you can look at the rationale for doing something different with the monies that could be drawn down from the federal government, it's a very rational argument. Nobody, and that was really demonstrated by the broad support that we have for House Bill 3791. I think I got the number right that time, and it included you know, what would be some very liberal think tanks, some very conservative groups out there. And they all came together and said, for different reasons, they said this is at least a start to get us in the right direction. Unfortunately, the press, you know, framed it as expansion of Medicaid, and it became synonymous with that, and that's unfortunate. I think one of the most valuable things, and I was having a conversation earlier this morning on this, is that to the extent that we can get an even broader, more solid stakeholder group together to let their voice be heard, especially the chambers of commerce, which represent the business interests out there. Texas Association of Business was on board with this. I think that is something that as we go into this next session, if the members hear loud and clear that their constituency wants something to happen, such as a Texas solution, for lack of a better way to frame it, then I think that, you know, there is the ability for us to, you know, get some traction with things. And I think that gives those of us, certainly on the conservative side, some cover, you know, in terms of, wait a minute, this is a pretty sound economic argument. How often do you have a chance to kind of alleviate property taxes for your constituents out there by virtue of something that you do at the state level in terms of policy? So.
Ma'am.
So I'm Alice Murray, and I am president of the Dallas Citizens Council. And like most of the other business groups, although the Citizens Council is thought to be particularly conservative, but a few months ago, we took the position to encourage support of covering the gap of Medicaid, Medicaid expansion, especially the Texas solution. So as we get a lot of groundswell from that, we have a lot of conversation about that position, because it's unusual for us to take such a liberal position. So it's created a lot of conversation, which is great. And so as we talk about it, especially with legislators, the one constant argument that they make without hesitation is that they don't trust, and you mentioned this, Representative Zerwas, they don't trust the federal government to keep their promise for 100% match that will slide to 90% by 2020, which is way out there. And they believe that it will go away, or that it will slip to the 60% that the current Medicaid program is. So how do you respond to that? Because isn't even 1 year of Medicaid expansion coverage better than zero? Isn't even 3 years of that coverage? How do you respond to that without saying, take it for whatever we can get from it to get those billions that are available to us that we've paid for?
Representative Coleman.
I would say back to them that the percentage of match and CHIP has never changed, and that it is still at approximately the 72 to 73% match that it was in the very beginning, and that program has been hugely successful, up to 200% of the poverty level, which it is now, and in terms of its robustness, it still exists under the Affordable Care Act. So there's a distinct answer there. In terms of our FMAP, the FMAP changes with the number of people who are uninsured. It just isn't changed statutorily. And I think that's extremely important for people to understand. And in looking at all of this, I would look at who changes something. So look to see if it's a democratically controlled Congress that changes the 90-10 or the 93-7 or the 95-5, or a Republican-controlled Congress that changes the whatever the case may be. I think that's a red herring. Just like in Texas, we can't bind another legislature, but a promise is a promise.
Sir.
Randy Smith with Texas Impact in Austin. I want to ask a little different question, but it's in a similar vein. Workman's compensation. Workman's compensation, there are many of our persons who are working, particularly in the housing industry, who are not covered by workman's compensation because they're considered to be independent contractors. Do you see any movement in the legislature of finding a way to deal with this condition that sends people who are working on a job and get injured on the job? They then show up at Ben Taub in Houston to get treated because they have no insurance and they have no workman's comp.
I didn't know whether you were going to tie it back directly into the conversation, but you did a good job there at the end. So what if I was going to glare at you, but you didn't. I didn't have to. So go ahead. What about that?
I think one, I'm not as plugged into the workman's comp, laws and services. Chairman Coleman can probably speak to those better than myself. But again, if you get to a point where you're offering affordable health insurance to people, of which is what we're trying to do during this period of transformation, in healthcare. That becomes the lesser of an issue, frankly, Correct. And so I think it helps us keep our eye forward on, what would, reduce our need for that kind of health coverage, if you will, and by having people that have more access to some type of a health insurance policy or a health savings account or whatever it might be.
Let me let you take a whack at it.
Yeah, I think OSIPs are the better way to go in terms of taking owner-controlled insurance programs. The better way to go in terms of taking liability all the way down to the sub-level independent contractor. And that allows a pooling of dollars that puts a bubble around everybody, both for workman's comp and for their bonding and liability insurance. These things have been working in construction projects. The challenge is, and you said it, whether it's somebody going to the emergency room at Herman or Ben Taub or somewhere else, or here, Parkland or Baylor or other hospitals, the reality is that cost is real and everybody's dodging paying for it. And so we can't have a system that says that the holder of the cost of everything is the person who has the least amount of money, who is out there on a job, who gets hurt. Because actually the job is being built off of and they hold the liability for the whole job in the final analysis. So this is a system thing that we need to deal with.
I am sadly being told that we're out of time. I want to take that last question.
Hi, I'm Representative Zerwas.
Howdy.
Representative Coleman, and this may be a question actually for Congressman Burgess.
It needs to be super fast because we are actually technically out of time.
Why is it that there are over 6 million Texans who have not taken advantage of the exchange program to sign up to get compensated care?
Very, very quick answer. Why are the 6 million or more who have no insurance not taking advantage of the opportunity to sign up?
Well, certainly not all of them qualify
That's
to
right.
participate in the exchange program. That's probably number one answer. Two, we're early on. As noted, there's time. The expectations of the administration were obviously much higher than that, but I think reality is checked in, and there's no program that's going to hit its full speed until it has a chance to really get, indoctrinated into the community. So
good, fast question. Answer. Good, fast answer. Sorry we don't have time for more questions. Bert, Michelle, Hillary, Aileen, Blue Cross Blue Shield of Texas, thank you very much for hosting us here. To Representatives Zerwas and Coleman, thank you so much for your time. Good to have you both on stage again. Thank you all for coming. We enjoyed it. We look forward to seeing you here again. Thanks very much.